connect. Okay, you mean a practice session, start webinar?
Start webinar, yep. That's great.
Get it started. Okay.
Okay.
Says it started.
Yep. So attendees should be, yeah, so I'm starting to see some attendees show up here, which is great. I'll give him a couple of minutes and then I'll just do a little introduction.
Great. I love your background.
Oh, thank you. Our design team has put together a bunch of these for the webinars.
So cool.
Kind of fun. Yeah.
I've seen some other things with that type of background recently. I like it. All the different breasts.
Yep. And you've seen them all, I'm sure.
I mean, yeah, we're trying.
Okay, well, I think as people are rolling in, just with time, I think I'll just do a little introduction to welcome everyone. And I'd like to welcome you, Dr. Potter, Dr. Elizabeth Potter, who is a board certified plastic surgeon and DIEP specialist. Dr. Potter guides her patients to embrace their own self-beauty and strength with a variety of advanced breast reconstruction, reconstructive, cosmetic, and aesthetic procedures. When helping patients along their breast cancer journey, she believes breast reconstruction and cosmetic surgery are intimately intertwined. If surgery is part of her patient's journey to looking and feeling their personal best, she's honored to be part of it. Dr. Potter is here today to speak to us about advances in reconstruction, tips on healing, and surgical planning to optimize healing. And along with her, she's welcomed some members of her group, Sarah, Whitney, and Heidi, to speak a bit about the topic. So without further ado, welcome, Dr. Potter. I just noticed, that the record button is not, it's paused. So you might have to hit the record again.
What?
So our audience gets it.
Let's see, pause, stop. Doesn't say.
Oh, there we go.
It looks good now?
Yeah, it's recording. Yeah, now it is.
Okay, great. Do you want me to get started?
Yep, jump right in. And the way it'll work for members in our audience is Dr. Potter and her team will, instead of doing a presentation, they're going to talk about topics right off the top. And then you can type in your questions in the chat box and I will share those with her.
And you'll be getting those questions, right, Jillian?
Yeah.
Okay, awesome. Well, I wish I could see all of your faces. I'm Dr. Potter, Elizabeth Potter, and I'm here in Austin, Texas. I specialize in breast reconstruction, and we have a wonderful practice here with, I think, 13 women who work with me. Or a couple of men as well involved, but it's a very empowered practice. Today I wanted to talk a little bit about what I've learned in breast reconstruction that's kind of revolutionized the process of breast reconstruction and the options that are available for all of you. It's been an exciting, I'd say, 8 years. When I first started training, reconstruction was very different. I feel like women were directed strongly into either implants or occasionally into reconstruction using their own tissue, but only at very select centers, usually academic centers. And those surgeries were very long and involved and not always as successful as they are today. So I've seen a huge improvement in the quality of outcomes from breast reconstruction. And I think over thousands of surgeries in my own practice, we've learned some lessons and tips that we wanted to share with you guys today. So feel free to ask questions, and just remember that, we're here in Austin. We take insurance for breast reconstruction. If you want to come visit us, we're happy to see you. We can do a variety of types of consultations, but would love to meet you in person if we can help. So I would say that off the top, the first things that have really changed breast reconstruction for me are women's choice. So I would, for like just this week, we did 7 deep flaps, 2 aesthetic flat closures, a female to male top surgery, and I think 4 tissue expander cases. So that's just a sample of 1 week here at our practice. And it kind of demonstrates that there are so many different options today for women to take advantage of. And I think, especially for this group of women who are young, that's kind of y'all's demographic, there are lots of options. And our whole goal here is to help each woman find the right kind of reconstruction, the right pathway to reconstruction for her. My role is not to sell a surgery to a patient. My role is not to prescribe a specific surgery to a patient. I think that everyone here on this team has learned to listen first and then offer guidance about what options are available. And then, we come to a decision as a team on what the best options are. So in general, when we first meet for a breast reconstruction consultation, we talk about the fact that breast reconstruction is covered under the Women's Health and Cancer Rights Act of 1998. So that means that if your mastectomy is covered by insurance, then your reconstruction is also covered. And that's an important sort of foundational point to make. There has been a history in breast reconstruction of surgeries being done cash pay or out of pocket, or with very large investment by the patient through out-of-network surgeries. So I'm trying to change that. And the best way for me to do that is just to have a practice that's a little bit different. And I think that's a really important point to make. So if you're finding yourself faced with large, like the suggestion that you have to pay out of pocket for surgery beyond your deductible, say, then I'd say keep looking, because there's a lot of us out there who do breast reconstruction beautifully, including, implant reconstruction and using your own tissue, and aren't asking for cash payments. So I think just this morning I got a question from someone out in the country saying, I was offered surgery and I was asked to pay $250,000. And I'm like, that's crazy. So just say no and move on and give us a call, right? So I think that, starting out with that foundation of understanding that breast reconstruction is covered is really important. After that, I think understanding that reconstruction comes in a couple of varieties, right? So just like this week, we did tissue expanders, implants, flat closure, and autologous reconstruction, as well as top surgery. Reconstruction can be using your own tissue. We do a lot of deep flap surgery here. It can be implant-based reconstruction, and it can also include aesthetic flat closure. And that's a really important option for women to understand. Some women just say, listen, I'm done. I don't want reconstruction to include another surgery on another part of my body, and I don't want an implant. And so we can do flat closures. I think that, as I said, our goal is to help each woman find the option that is the most empowered choice for her. For me, I love doing this work. I think it's important to me to do it because I like helping women feel like their best selves, right? It's not about feeling, it's not about beauty really, right? It's about feeling at home in your skin and feeling like you can move forward and do all the things with your life that you want to do, thinking less about your body, right? And more about your purpose. So I think we've found this work to be really empowering because it helps women kind of move on from this challenging position. Is this a good time for me to introduce the other folks?
Sure. Yeah.
Okay. So my goal, and you guys meeting some of the team, kind of speaks to one of the advances in Reconstruction. So it's not just me, right? Here, it's a huge team, and it takes really careful preoperative care, intraoperative and in the hospital care, and then postoperative care. Since we do a lot of deep flap reconstruction, they're going to speak specifically to some tips regarding that, and just give you a little bit of the wisdom that they've learned in terms of how to optimize healing and move forward in the most empowered way possible. Okay, so the first person I'm going to introduce, I think, is Heidi Burns. She's a PA. All these ladies are total pros, and nobody who works with me isn't. But they each bring their own expertise to the table here. So Heidi's going to talk first. After her, Sarah Elmer is going to talk. Sarah was actually a PA for one of my mentors, and I was so lucky that she joined me in practice. And then after that, Whitney Winters, who is a nurse practitioner that I first met in the hospital, who took care of our deep flap patients as one of the charge nurses. And when I heard that she was going to be a nurse practitioner, I begged her to come and work with us, and she does now. So, okay, so Heidi Burns first. All right.
Hi. Hi, Heidi. Welcome.
Thank you. I also love the background. This is great. Well, as Dr. Potter said, I'm a physician assistant. I work with our team here in the clinic and also work in the hospital, seeing patients after surgery. And I also work in the operating room assisting in the surgeries. So I'm really lucky to be able to kind of have a part in the entire process. Really enjoy that. So I'll be talking a little bit about how we help patients prepare for surgery. And I think that it's, I've worked in a couple other surgical specialties, and this one is really special because it, having all of us so involved in the process means that we get to know patients really well, just around the whole process. There's not one specific person who is only involved preoperatively or in the hospital or postoperatively. So it's really great to be able to get to know patients throughout that process, and for them to get to know us, and it turns into some really great relationships. But I wanted to kind of start talking about like a pre-op visit in the sense that it's not just us checking on medications and allergies, things like that. It's not us just giving a to-do list to a patient to what they're supposed to do next. It's really just talking about, what is important to that person and what your home life looks like. What is your occupation? Are you a caregiver for small children or an elderly parent or even a spouse? Those are all really important things for us to know so we can help really optimize their recovery and make the experience the best it can be. So I really enjoy that part of seeing patients preoperatively. And we ask a lot of questions about, what they do for work and what they're required to do physically, either for a job or around the house, what they like doing. There's a lot of patients that say, when can I get on my Peloton again? Or, when can I get in the kayak? And all of that is going to be very different for each patient. But I think kind of setting some of those expectations on what to expect helps people mentally prepare for what lies ahead. And also on that note, it's really fun seeing patients come back during their recovery and a lot of the time say, this is a little bit easier than I thought it was going to be. So not always, but I think just having those discussions preoperatively really helps us, again, get to know each other and set everybody else up for success. So we talk about things like, again, family support. Is there someone there to help them with drain care and dressings, driving them to appointments, at least for a couple of weeks until they feel like they can do that and they're off of any pain medication and they're recovered enough to be in a position to drive themselves. I think having those conversations on what is safe to do and when is really customized per patient. And also, seeing what the home is set up like. Is there a bathroom and a bedroom on the main level? Is there a recliner in the home? Do they have a place to sit down in the shower? Things like that we have found are really valuable to talk about before surgery, so we can kind of prepare and not have as many surprises after surgery to account for. We usually have patients set up with a walker to use, and Sarah will touch more on that about what goes on during the in-hospital recovery. But it's really great to have those things set up, like a recliner, place to sit in the shower, things like that, and planning for where will I do my immediate recovery at home if my bedroom and bathroom are upstairs. So it's all about planning. So there's a couple other things that we talk about too, like, a lot of people have pets. Dr. Potter has 6 dogs at home, and I personally have 3. I think a lot of us have our fur babies at home. And sometimes, you need to kind of make arrangements for where those fur babies are going to sleep. So we decrease infection risk and things like that. We also talk about nutrition a little bit before the surgery and how that can help optimize recovery. So it's a whole lot. And sometimes the pre-op visit, it's not just a 5 or 10 minute appointment, it can be 30, 45 minutes sometimes, and it's all time well spent. So that's just kind of a little bit about what we talk about before, say, a deep flap reconstruction surgery. Any questions about any of that or anything I can help clarify?
Anybody within our audience have a question? No, not yet. No.
Awesome. So, well, I might hand off to Sarah Elmer, one of our other physician assistants. She'll be talking a little bit about the things that we monitor in the hospital and how we help kind of optimize recovery and the experience for our patients. So thanks for having us, and enjoy talking to all of you, even though I can't see you. And Sarah will take it away.
Hi, Sarah.
Hi, hello everyone. I'm Sarah Elmer, as Heidi just said, and I'm another one of the physician assistants that works with Dr. Potter. And I'm going to talk about the inpatient care after a deep flap surgery. So I think this can be one of the most difficult times, both mentally and physically, for our patients. Right after they have surgery, everything seems a little bit overwhelming. And so we're that kind of constant for them, and they're throughout all of the aspects of it. We also have really amazing nurses that we work with day in and day out, and those nurses are always the same. So we have a really great team in the hospital for post-op care. And so some of the things that we do, just kind of walking you through a typical inpatient stay. Most patients after a deep flap surgery are in the hospital for around 72 hours. So that first day after surgery, there's more of like a clear liquid diet, have you on bed rest, have some warming blankets on, keep you nice and cozy. And then that first day after surgery is when we kind of have you start getting up a little bit. And with the deep flap surgery, positioning is very important because of the abdominal incision that goes across the entire abdomen. And so we're needing to keep patients in a flexed position. So Heidi had mentioned having a recliner post-op and using a walker. And so having those things keep you in that nice position. And we check on that, the nurses check on that. We have everyone making sure that you're in that position. So when you're getting up out of bed, the nurses, physical therapists are helping you. So you have that whole team support, throughout, kind of reminding you of those things, which is nice. And then on the second day after surgery is when we have you start walking more in the hallway, and you have your cheerleaders with you then too, the physical therapists and nurses and the team, Dr. Potter and my co-PAs and NP. So that's kind of physically what you're going through. In terms of wound care, we do a lot of things to kind of help prevent infection. We wash the incisions every day with a solution called Wash, which is antimicrobial. And then we also use a silver Meplex dressing, which is antimicrobial along the abdominal incision. So we are very careful in terms of preventing infection and have you on antibiotics as well, both in the hospital and for a week after surgery as well. And then one of the most important things that we have you in the hospital for is obviously monitoring of the DIEP flaps. And so in the hospital, the nurses are monitoring the flaps every hour. So they do a visual flap check every hour, potentially check for Dopplers, and then we have constant monitors called bioptics on the breast flaps while you're in the hospital. And that's actually something that we can see on our phones from anywhere. So we can look that up at home even and know how the flaps are doing. And so that's great for us to be able to know at all times how the flaps are doing. So there's lots of different things that we do. I think one of the most important things in this immediate post-op period, again, is just support. And so having family support is also really important. And we kind of set you up for that preoperatively in terms of, you know, having the family members there for you. But we always make sure that a family member is able to be present on that last day in the hospital so that they can see the wound care. So we're showing you firsthand how you'll do the dressings at home, how the bra is put on, you know, how bent you need to be and how to get around, do showering, just all of those little things, the drains. So we're able to kind of show everyone firsthand, both the patient and the family, how those things will be done so that there's, you know, no question once you're home how to do things. So I think all of those little things that we do to set you up for success. Sorry, do you have a question?
Yeah, we have a question from our audience.
Sure. Yeah.
It's a long one, so I'll read it. And then I'm not sure if you can answer it or if Dr. Potter should answer it. It's from Allison Heil. I hope I'm pronouncing your last name correct, Allison. How does the live tissue metabolize once it's from your belly to your breast? If you lose weight in your belly, will that tissue in your breast also reduce? Vice versa, if you gain weight in your belly. Allison is in Seattle and planning on the depth surgery in the spring after her chemo is completed. Oh, and Allison says it's Hill. So
Okay.
that, Allison.
Perfect. Great question, Allison. So with the DIEP flap surgery, that is, you know, we're taking that belly tissue and bringing it up to the breast. We're creating a new blood supply. And so that tissue lives in your breast now. And so it is your own tissue. So if you do lose a significant amount of weight or gain a significant amount of weight, you can see changes in your breast volume with that. We've noticed that if you lose, you know, a mild amount of weight, 5 to 10 pounds, you're not really going to notice much change. But if you are gaining and losing a more significant amount, you can notice changes in the volume. Wonderful question.
Does that answer your question, Allison? I hope so. If anybody has any more questions, just type them in and I'll just interrupt in the middle and ask. All right, thank you.
Perfect. Yeah. Well, I think that kind of covers everything with the inpatient management. And so at this point, if there's no other questions, I'll go ahead and turn things over to our nurse practitioner, Whitney Winters, and she is going to talk about care after the hospital for those weeks recovering.
Right. Hello, everybody. My name is Whitney, as Sarah said, and thanks so much for having us today. Hi. So I'm going to be talking a little bit about post-op care. I help out a lot with the post-op care in the clinic. And so I'm just going to talk about some of the specific things that we do after surgery and kind of in that 4 to 8 week recovery period. So the first post-op appointment is usually 1 week after surgery. And so at that time, we're assessing the incisions to see how they're healing and taking a look at the reconstructed breast, making sure that they are soft and warm and well perfused. And then typically we're able to take out both of the breast drains at that visit. So the breast drains are out and one abdominal drain usually comes out at that visit. And then we talk about wound care as well. So as Sarah mentioned, we use a Mepilex dressing over the abdominal incision. And so that's for the first week after surgery. So at that 1 week post-op appointment, I typically tell the patients that they can stop doing that and that they're just going to continue to take a daily shower with soap and water. They're going to apply that Bosch solution onto their incisions, and then just apply some gauze padding over their breast incisions with the clean bra. And then they can either wear some high-waisted underwear that goes up and over the incision so it's not causing any irritation, or even something simpler than that, like a house dress or some loose pajama bottoms are typically comfortable for patients. At that visit also, we're assessing or looking at the tissue to the lower abdomen and seeing if it's ready to start undergoing a little bit more tension, and the patients are usually able to start standing a little bit more upright. So Sarah and Heidi mentioned that we usually have the patients walking bent over for the first couple weeks after surgery. So it's a gradual process of getting people to stand more upright. So each visit we'll review positioning and tell the patients that they can start walking in a little bit more straight position. And so the walker, usually at the 1 week post-op appointment, I'll raise that by 2 or 3 pegs and tell them to keep using that, but they can walk in that new position. And then the visit following that would be the 2 week post-op appointment. And then some patients are ready to start walking straight at that point. And so it's always a relief to the patient when they're able to start walking straight, because that's a little bit more comfortable for them as they continue to heal. And then really the wound care stays the same until they're healed. And so they're going to continue with the daily showers and with the bra and things like that. At that point, that's going to stay the same. At this point, the 2 week post-op mark, they're usually off of their pain medicine and just taking over the counter medicines like Tylenol or ibuprofen. Which is a great thing as well. There's a lot of side effects from the pain medicine, so it's good when they can wean off of that. And then typically the next appointment after that would be at the 4 week post-op mark. And this is always the patient's favorite appointment because we go over a lot of activity that includes being able to increase their activity a little bit more. So patients can usually start to be walking a little bit more comfortably in an upright position. They can start to do a little bit of light aerobic activity to get their heart rate up a little bit, lots of walking throughout the day. They can also stop wearing the bra at night, which is a relief to them. They can transition back into bed at this point instead of sleeping in the recliner. And then we also have them start practicing something called bracing, which is just something that they can do throughout the day to help to re-engage their core muscles a little bit. We don't go through the core muscles at all with the deep flap surgery, but we do have them on that light activity for that first month after. So it's just kind of a way that they can start to re-engage those muscles a little bit since they've been on modified activity for the last month. And then the visit after that would typically be at the 6 or 8 week post-op mark with Dr. Potter. And really from the 4 week post-op mark out, it's just a matter of gradually increasing their activity. At the 6 to 8 week mark, we typically give them patients some floor exercises that they can start. And really after that point, there's not any activity restrictions except for some weighted core exercises. So something like doing a crunch with the weight on your chest. That's something that we typically tell people to avoid doing until they're 4 months out from surgery. But other than that, usually at that 6 to 8 week mark, people are able to go swimming or start exercising normally again, lifting weights and things like that. So that's kind of our normal post-op course for our patients. Does anybody have any questions? Yeah. No. Okay, good.
Nobody's typed anything in. So.
Okay, sounds good. Well, then I'm gonna have Dr. Potter come back in, and it was so nice to meet with all of you guys today. Thank you.
Great. Okay, I'm so glad that you guys got to meet some of the team. You can see that it takes a lot of professionals functioning at kind of their highest level to deliver this care. I'm so proud to get to work with these ladies. So thank you guys. So I just wanted to address that question from Allison. So Sarah answered absolutely what I would say. And the other thing I'd say that's nice about deep flaps is that I feel like with an implant-based reconstruction, you're getting an implant that's a specific size, and that size doesn't change with you. It comes out of a box and it has very specific, dimensions. But with a deep flap, if I get the proportions right, if we get the proportions right in surgery, then those proportions kind of adjust with you, right? With natural weight gain and loss. So I think that's one of the advantages of using your own tissue is that it does kind of, it's living and it changes with you. So we've definitely seen patients who maybe weren't at their ideal weight, their own personal ideal weight when we did deep flap. And then, really took advantage of a refocus on their health and lost a lot of weight or gained weight if they needed. And we find that reconstruction is still beautiful and in proportion with those changes. Good. So any other questions before
I do have a couple questions that were sent to me. They're not part of our audience that they didn't send in. So can I start with that?
Yeah.
So there's been a lot of discussion and concern around what is lymphedema, and how can one avoid getting lymphedema after they've had surgery, and how do you know if you have it? Can you develop it later on, or is it something that happens right away?
Sure. Those are great questions. So lymphedema is something that can happen when you've had an impairment in the lymphatic flow, and in this case, your arm. So there's a separate circulatory system in your body that's not blood, but it's this fluid called lymph. And when we remove lymph nodes, or when we damage the lymphatic system with things like radiation or surgery, then you can get a backup or blockage in that system. So it's kind of like you're driving down the highway and there's a wreck in the highway, right? Things back up, traffic backs up. So the swelling that you sometimes see in an arm is just the backup of that fluid because it can't get through the armpit, or it can't get through the radiated and scarred tissue. I think that lymphedema happens, I know it happens more often in women who have radiation and women who have a complete axillary dissection. So that means removal of all of the axillary contents. So for women who only have a sentinel node removed, or 1 to 3 lymph nodes, the risk of lymphedema is lower. But it's different for every woman. I think that I would encourage women who are undergoing treatment for breast cancer to, seek out a lymphedema therapist and talk about some preventative measures. It's hard to predict who will develop lymphedema. There are some surgical procedures that we can do after, but they're not wildly successful.
Could you, after this session, provide us with some names of lymphedema specialists that we could share with our group?
Totally. Absolutely. Yeah. I know several of them. One of them is David Chang at the University of Chicago that Sarah worked with. Yeah, I trained under him at MD Anderson, and he's spectacular. Yeah, absolutely happy to do that.
Awesome. Thank you.
Yeah.
And I did see another, I don't know if you're finished talking about lymphedema, but there's a question in the chat box.
Sure. I saw that. So will a deep flat breast?
From Mary Price, and she writes, will a deep flat breast and a breast that is not reconstructed change symmetrically when you lose or gain weight?
That's a good question. A breast that is not reconstructed. So I guess a deep flat breast will change as you gain or lose weight. If you're talking about a breast that's not reconstructed, so I think that if you mean like a flat closure, then certainly the subcutaneous fat that's underneath the skin will fluctuate. I think that if we're comparing one side to another, so if you have a deep flap on one side and you don't on the other side, obviously those sides will be not symmetric. I do think it's important to point out that if you've been radiated, then your body will not gain and lose weight in the same way on that radiated side. The forces of radiation and the forces of contracture there are just stronger than weight loss and gain. So you will always see a tighter chest on the side that's radiated.
That's been my experience too. I had bilateral mastectomy and only radiated on one side, and it's always a little more tight and higher than the other. So I've had a few reconstructive surgeries to kind of make them more even. But
That's hard. It's like, the forces of radiation are strong, and that's something that I can't, there's no surgery that I have that can reverse radiation. There's surgeries that we can do to work around it and try to maximize symmetry, but that's a challenge for sure.
We have a couple more questions here. I'll just read them. Oh gosh, read them for our audience. We'll move up. Kate Lee asks, I know DIF reconstruction isn't for everyone, but it sounds like a long recovery. In general, what are the pros of DEP over other options besides it being the patient's own tissue? Are there other main reasons that you see patients choose it over other options?
Gosh, these are great questions. And if you guys feel like you have something to add, please pipe in. So I think that I don't want to sound like DEEPs are the only way to go. I just do a lot of them. And I think I do a lot of them because there's not a lot of folks doing a lot of them. Breast reconstruction should just be tailored to the woman. It should be the right thing to do for you. But if you're asking me, what are some of the advantages, other than it just being your own tissue, I think that it's all about what feels most natural for you. What feels best to you. And some women just know that. They know they don't want an implant, or they know they don't want to be flat, or they really do want something that's more natural. I think, there are some shape advantages to DEEP flap when we do it really beautifully and well. There's a lot of art to reconstructing a breast using your own tissue. I feel a lot of personal satisfaction in creating a breast that looks really natural. It's easier for me to do that with your own tissue than it is with an implant. Implants come out of a box, right? They're a certain shape, and I can't change that shape. But as a surgeon who does reconstruction, I can really work to make a breast out of your own tissue that suits your frame. So aside from it being natural, I think it's just a bit more malleable and customizable to the woman, if that makes sense. I mean, and you can't discount the fact that we're really good at this and the belly looks so pretty, right? So it's nice at the end of the day to say, okay, well, we're faced with this really hard circumstance and we're going to try to make something positive out of it. And I love taking all of my cosmetic skills and giving it to breast reconstruction patients, right? I take a lot of pride in that. So I think the whole team does. At the end of the case, Sarah and I were operating yesterday and we looked down and we're like, yes, we feel that way. We feel like this is the universe, exacting a little bit of justice. Let's make this look awesome.
And Dr. Potter, when you have the DEP surgery, I know I have implants, and I had to make the decision very quickly. When I found out I had stage 3 advanced breast cancer, I found out I was pregnant at the same time. And I had 11 days to decide what I'm going to do. And I'm not sure I would make the same choice if I were to do it again. One of the things that's really affected me, my intimacy with my husband, is that I don't have the same feeling in my breasts that I used to have. And so when a woman elects to have the DEP reconstruction, is that an advantage over having what I had done? Will they have feeling again or not?
No, I think that's a great question. I think that the loss of sensation is part of mastectomy. So when you remove the breast, you remove all of the structures that course or go through the breast. And that means a lot of those nerves that are going to the skin and nipple running through that. Now, so I think that, starting point, good mastectomy, you're going to lose sensation. Now, can we restore some sensation? I think that, that's a separate question. In advanced in breast reconstruction, we are working on, is there good data to support resensation or reinnervation of breast tissue? And that the jury is still out on that. As plastic surgeons and reconstructive surgeons, we're very good at doing nerve reconstructions. We do that all the time. But for the breast, for the size of the nerve and the distance that you have to travel, we still need to refine that process. So I don't think that I'm comfortable today saying that, yeah, I can restore your sensation in a breast at the time of reconstruction. I don't think that that is necessarily a benefit of choosing one type of reconstruction over the other. Now, I'm completely open to the fact that that is an evolving field and we may have data in the future that supports that, but I don't today put in nerve grafts for patients because I don't see the data to support that that actually works. What I will say is that our patients who have reconstruction using their own tissue tell us that the flap feels like themselves, like it feels like theirs, whereas someone with an implant often says it feels like something else. So there is that sensation or that feeling of being in your body where pressure against a flap feels different than pressure against an implant. We have had patients who had over time sensation return from the outside in towards the breast, and that can happen. But I don't think that, I think that the losing sensation is, one of the challenges of cancer. I hope that we get to a place where we are able to restore sensation more successfully. I am not a salesman for surgery, and I would never lie to a patient about that. So today, I would not say, choose a flap because I can give you sensation. I would say, choose a flap if that's what you want to do, and we're really good at it.
Thank you for that. There's a couple more questions in here. There's two questions, quick ones, I think. I've heard other patients talk about phases or stages regarding surgery. Are there multiple surgeries with DEP in addition to the main one? Question one. And question two, is it true that if you have what does it say? Is that true if you have radiation?
Sure, I think she was referring to that earlier question.
Okay, yeah.
Okay. Got it. These are great questions. So stages. So when I was in training, this was like the deal. It was like, 3 stages to breast reconstruction. And there are a lot of things that I was taught in training that I just thought, I'm going to do better than that. And this is one of them. I think that our goal with breast reconstruction is that first we do the cancer operation. And oftentimes we place a tissue expander at the time of the mastectomy in order to do the right cancer surgery. Once we've had the cancer surgery done, we have negative margins, we've done all the treatment, all the radiation that needs to be done, margins are clear, then we can proceed to the reconstruction part. This is for someone who's not a prophylactic patient. But once I'm doing a deep flap, if I'm in the operating room doing it, my goal is that we leave the operating room not expecting to do revisions. So we're doing we're getting their sides looking good. We try to get your symmetry just right. If we do a revision, it would be a minor revision at about 4 months after surgery, but I don't personally believe in staging. Like, who has time for that? I just think we're all living like busy lives, and I think you want me to go into the operating room expecting to knock it out of the park. And that's kind of the way I look at that. So we don't talk about stages here. We don't do stages. We just try to do great surgeries, and then we adjust if we need to. And then the question about radiation, yes, it is true if you have radiation before your body changes. And then there was, can you share nipple options for DEEP patients? It's a great question. We do a procedure here called dermal pedicle nipple sparing that some women are candidates for. We just presented at the national meeting on that. Dr. Julie Sprint is a breast surgeon I work with here who has helped us develop that technique. She's amazing. I highly recommend her at Texas Oncology. So yeah, if you have a low nipple and you have a cancer that allows for it, there are some options for trying to save your nipple. The risks are higher. And I think that question of, can I lift your nipple and save it, is an important one that we have to think about. If you have a nipple that's not low, that's kind of in a position where you like it, and your cancer does not come really close to the nipple, then absolutely, we can work to save your nipple at the time of the mastectomy. And I would say really important there is choosing a great breast surgeon who knows how to do nipple sparing surgeries, who isn't just dabbling in breast surgery, who does this a lot, because it's not easy to save the nipple. But if your cancer is near your nipple, then we have to take the nipple away. Or if you're someone who has who really wants to control risk maximally, and you want to remove your nipple, then we have options of doing usually a 3-dimensional tattoo later. I don't personally like the results of nipple reconstructions. I will do them for patients who want them because it's their body, but I'm super honest about the fact that my goal is always to do a great job, and nipple reconstructions are just not great. They flatten out over time. They leave scars. If you gain or lose weight and your breast moves, you have scars that move in different places. Like, to me, being able to adjust with a tattoo is just, I don't know, better. The nipple sparing procedures, I think all of them boil down to a really important concept that I'd love to talk to you guys about another time, but it's the concept of risk tolerance. And this is like mission critical in making your decisions for breast reconstruction. So I personally have a low risk tolerance. That's me. I like to control risk for myself and my patients. Some patients come and see me and, they're 11 days into a diagnosis and they have a baby on the way and they're like, game over, get it all out of me. Don't save the nipples. I'm done and done. And their risk tolerance is low. They want to just maximally manage risk. Other patients say, my nipple is really important to me and I will accept some risk to try to save this. I think the point is that a lot of breast reconstruction isn't completely prescribed. It's choice. And you have to find a surgeon who will work with you to achieve like a balance that's medically safe and suits your goals, right? So I'm not going to do something that I think is dangerous, but I will do surgeries that I might not want personally for myself. Like, I might do an immediate deep flap for someone with a very tiny cancer. I wouldn't choose that myself, but it's reasonable to do that for someone if they understand the risks involved. Does that make sense?
Mm-hmm.
Okay.
Yeah. There was a question here, and I know there's a tattoo artist who's very well known on the East Coast here, but the question is, who do you suggest to your patients wanting 3D nipple tattoos? Is it covered by most insurance?
So that's I use that tattoo artist on the East Coast. They would come to my office, Vinny. Yeah.
Yeah,
So before COVID, they would come here and tattoo. COVID has changed a lot of things. We have tattoo artists here locally or in the area that are really good. There's some in Dallas and in San Antonio. I think it's most important to see the work and know that the results are good. I think talking to other patients about it is great. I can send you afterwards a list of some of the folks that we use. Yeah. It is covered by most insurance, but I will tell you that for a beautiful reconstruction, a beautiful nipple tattoo, you might be paying out of pocket. A lot of folks don't take insurance for those tattoos.
Mm-hmm. Okay. The next question is, if you have a breast reduction in one breast and a mastectomy with implants in the other, and then get breast cancer in the reduced breast, can you have reconstructive surgery with an implant in the reduced breast? Are there risks or things to know about this process?
Okay, so if I read this right, you've had a mastectomy on one side already and have an implant. And you have a breast, okay, so you have a breast cancer on the other side, you've had a reduction. Yeah, you can have an implant reconstruction on that side. Sometimes we're not able to save the nipple on that side. Sometimes we can. So I would say the specific risks associated with having a mastectomy after a reduction are very similar to having a mastectomy before a reduction. They just include an increased risk of nipple loss. But you can absolutely have reconstruction on the side that's been reduced previously.
We have a question here. Reads, I was diagnosed BRCA2 and had a tumor in my breast removed, which was stage 1. And an oophorectomy identified tumor stage 1A in fallopian tube in 2020. Mm-hmm. Do you recommend a double mastectomy?
Oh, yeah, I'm going to stay in my lane there. So I would say that's a great question. So if I hear that correctly, there's a diagnosis of fallopian or ovarian cancer. So number one, I'd say treat that first. Like, that takes priority 100%. So once your treatment for that is, and I face this not I face this not frequently, but in our practice where someone will come in with ovarian cancer or fallopian cancer. And I always say, let's knock that one out first before we address the breast. So I'd say first complete your treatment for that. Make sure you're not immunosuppressed from that treatment. And then, the question of having bilateral mastectomies, that's such a personal question. I think it's really valid to consider it. If you were my patient and you were sitting in front of me saying, I have BRCA2, I've had a cancer once, I still have my breasts, I've only had a lumpectomy, I've also had an ovarian cancer, I think I'd follow up with like, hey, why are you here? Are you here because you're thinking that you want to have mastectomies? Because that's a reasonable thing to think about. And it's a really personal choice. When you're going to sleep at night, are you worried about your breasts? Like, do you have family members who've had breast cancer at a young age? Like, all of those things are reasons why it's really reasonable to think about having mastectomies. But I'm a plastic surgeon. I am not here to tell you to prescribe like the specific risk for that. But I am here to support you in doing a beautiful reconstruction if you choose to do that, and to tell you that it is very reasonable to decide to remove your breasts if you have BRCA. I mean, it's also reasonable to not remove your breasts if you want to bear that risk. So I hope that it helps.
It does help. There's a couple more questions that were sent to me, if I could just address those. The first question is from somebody within our community who is very, very thin framed and with, I would say, 0 body fat. She had a double mastectomy with tissue expanders, and then they did the swap for implants, and she's very disappointed with how it looks, because she basically thinks it's just like 2 lumps on her shoulder, on her chest rather. Yeah. And she's wondering what might be her option. Like, can she switch out, and then like, would she be a candidate for the flap, or is there something else that she could do? What would you recommend?
Yeah, so I'd say in Austin, we have a lot of patients who are thin and athletic. And, I think I'm always up for a really nice small breast reconstruction if someone wants that. I think that if you're unhappy with an implant reconstruction and it doesn't feel natural, there's a couple of ways to approach that. Sometimes we can, change the plane of the implant, and that helps. Sometimes we can put a tiny flap on top of an implant. So that can, that's a really pretty result. That's sort of like, breast reconstruction 405, like graduate level breast reconstruction, where you have an implant and I go in and I do a buried flap just to recreate the breast gland, just for that buffer. That even in a thin person, that's almost the best option. So if they have a little bit of skin on their belly or a little bit of skin below their bottom, and for another flap called a pat flap, then we can lay that flap over the implant, put a smaller implant in. It takes away that rippled look of the implant and gives just a more natural look. And then some women say, I don't want an implant at all, just make me a really tiny little breast out of my own tissue. And I'm down to do that. Like, I think who's to say what the most perfect breast is, right? If you want me to make a small breast, I love it. Yeah.
Maybe I think I should put her in contact with you then.
Totally. Yeah, happy to. Yeah.
And then the other question that seems to be coming up among our community is this topic of textured implants. Can you talk to us a little bit about that?
Oh yeah, sure. So textured implants are linked to breast implant associated lymphoma. So most plastic surgeons, I'll speak for myself, I do not use textured implants at all in practice anymore. Now that I know the risk of breast implant associated lymphoma. So I also think that there are a lot of women out there who have textured implants that were placed in breast reconstruction. And so I'll speak to that specifically. So this is not advice for women who do not have a history of breast cancer or risk and have textured implants. So I'm not speaking to women who have a cosmetic textured implant. But if a woman has a textured implant that has been placed in breast reconstruction, I think it's very reasonable to remove that implant and replace it with a smooth implant. That's what I would do. That's what I would tell my sister to do.
And is that something that is typically covered by insurance?
Yes. Yeah.
So you have it removed and then you swap it out for a different type?
Yeah, I would, to control risk. I think most women who've had breast cancer have, back to that concept of risk tolerance, they've kind of rolled the dice once. Like once you tell them that there's something in their body that we can remove that carries additional risk, most women who've faced breast cancer will say, I would like that removed now.
Yeah.
Now, that is in contradiction to probably the opinions of a lot of plastic surgeons. And I've gotten some nasty emails from other plastic surgeons for saying that, but I just think that's my best advice. I would not personally keep a textured implant in my body if my body had made a cancer once.
Yeah.
Right. So insurance will cover that.
Yeah, for sure.
Yeah.
Are there any more questions from our audience that we'd like Dr. Potter to address? I think we answered all of them in the chat box and the Q&A.
Well, thank you so much.
This has been great and super informative.
I'm so
And so you'll follow up with a list of lymphedema experts that I can share with this community who you recommend, and also a list of tattoo artists. And I just saw one question just pop up again. A thank you to you for, this has been awesome and informative. So I agree. I know that this is a topic that comes up a lot when we, reach out to our community and ask what are you wanting to see or talk about during a webinar? And it's always this, it's a big question for women, it's a shocker when you find out you have breast cancer, and then to navigate through all the information can be really overwhelming on choices that you have for, reconstructive surgery. So thank you for sharing this session with us today.
Oh no, thank you. And we're available, this is my life's work, and I'm here to help. And I think for so many women like you're faced with these questions, and you have to make decisions in a really hard and stressful time. And sometimes it's helpful just to rethink those decisions or just talk through the options. Even if you don't change anything, just that conversation can help you feel empowered. So yeah, we're here to help.
Awesome. Well, thank you so much. And thank you to everyone for signing up for this webinar, and we'll see you next time. Awesome. Have a happy holiday. Take care.
Bye.
Bye.